Hello, Brian Balke of Hypnosis Rising, here to give you an introduction to the first of our therapeutic techniques, the Rigidity Challenge. In our last lecture, we built a comprehensive sleep therapy. Step by step, our trance work addressed the factors that prevent effective rest. Only when those factors were dismissed in trance did we turn to building new compacts between the conscious and subconscious. We will see this pattern in all application areas. Loosely speaking, the professional skill of the histotherapist lies in sequencing techniques to build a therapy. With sleep therapy as our model, in the next few lectures you will learn to apply the techniques used in sleep therapy. In each case, we will address not only the mechanics of the technique, but the psychology that motivates its use. Over time, as you employ each technique in therapy, you will build intuition that will provide spontaneous guidance for their use. Why is this important? Well, sleep therapy is simple enough that we were able to prescribe an investigative strategy that provided all the insights necessary for the trance work. In most applications, however, we will receive critical insights in trance. We will be compelled by these insights to enhance the trance strategy in real time. In the context of today's lecture, we anticipate that as skill evolves, we will find ourselves realizing, oh, here's an emotional block that wasn't revealed in our investigation. Let's add a rigidity challenge to soften the resistance to change. Today's technique, the rigidity challenge, deals symptomatically with emotional resistance. The resistance arises when we are punished for trying to avoid social distress. The mind channels the distress into the body, creating a syndrome such as a hunched posture or nail biting. Until that subconscious link is softened, therapy will be undermined by the persistence of physical discomfort. The rigidity challenge softens the link between the emotion and the body, allowing the physical discomfort to dissolve. We start today's lecture with a gentle dive into the psychology of triune disorders. We then describe a progressive breathing meditation, starting somewhat like the familiar Buddhist practice, but leading beyond thought control to release of inner tension. This practice is essential for clients harboring layered complexes of emotional distress. Your course materials include a one-sheet to guide them. We then turn to the rigidity challenge, first as a deepener and then as an induction. From our applications lecture, you may recall that triune disorders are a primary branch of therapy. That survey was abstract. As the techniques we'll cover today address triune disorders, now is a good time to look at a simple case history. How does a triune disorder arise? Once those patterns are understood, we can understand how idiomotor diagnostics use triune links to expose knowledge and preferences hidden in the subconscious. A triune disorder, as with all behaviors, arises through a learning process. All learning begins with recognition of a pattern. Here we have a distraught child who, having built a truck, anticipates that his sister will stress test it to destruction. This pattern is encoded in the brain as a signal fired onto an axon. Naturally, when first recognized, that signal has yet to connect to networks that organize an effective action. Should the pattern repeat, the axon will reach out, stimulating other networks. Initially, this seeking will tend to be disruptive to other behaviors. Clearly, this is intolerable. The brain prevents lock-in of those patterns through psychological compulsion that persists until a solution is found. Under the force of this compulsion, our tormented youth may scream, bite, barricade his door, or smash his blocks with a hammer. The last according to the ancient principle, if you can't join them, beat them. Once our friend has found a behavior that disrupts his unhappy pattern, the compulsion fades. Let's say that his sister flees when he screams. This allows him to enjoy his blocks until mother starts to work afternoons at home. Now a far more powerful person tells him that his solution is unacceptable. What to do? Ideally, mother would mediate between her children, finding a less disruptive solution, such as telling sister that stress testing should be deferred until brother wants to repurpose the blocks for another construction. If mother is preoccupied, however, the screaming may be the only evidence of unacceptable behavior. Son is told not to scream, and sister resumes stress testing his designs. In this case, the tendency is to prepare a scream, hoping that the signs will deter sister, but to stop before unleashing the sound. This creates internal tension, which may be sustained if sister enjoys inflicting torment. Our vignette has a satisfying rationality. If in adult life our client grinds his teeth, we can explain the origins of this behavior and use dream therapy to release the concern that drives it. But it is not always so simple. In infancy, a repeated crisis cannot draw upon language and motor skills to invent a solution. The baby may react to no by regulating hormone releases or holding on to gut contents. This occurs in deep pre-verbal networks. In such cases, therapy focuses on rechanneling of the blocked emotion through rigidity challenges. When inner tension is chronic, changes in muscle tone may trigger tics and twitches. This evolves naturally through lack of exercise and aging, but also as the tension is released. That our reactions formed in infancy lie latent in our minds is the foundation of idiomotor diagnosis, a practice that seems absurd to the logical mind. Most common is the pendulum bob, held loosely in the fingertips while the elbow is anchored to the table. The client is asked to meditate on a yes or no question. This method is a powerful tool for penetrating reasoning to reveal how the deeper levels of personality are affected by our choices. Why does this work? In infancy, yes and no are expressed through gross motion. No perhaps by pushing away with the entire arm, yes by gripping tightly with the fingers. This expression is unique to the individual. Once we learn to talk, however, we are told to use our words. As with triune disorders, we do not unlearn the physical action, but rather suppress it. The muscles still tense slightly, but other networks suppress the motion while triggering speech. It is the residual tension that generates the characteristic motion of the pendulum bob. We ask the client to meditate on yes and note the shape of the bob's wandering. This is repeated with no. We then ask the client to meditate on a yes-no question, and the subconscious expresses its preference, and the residual muscular tension revealed through the motion of the bob. In Buddhist thought, the projection of social conflict into the body is a form of attachment. In one form of therapeutic meditation, the acolyte focuses on their breath, seeking to quiet their minds. When intrusive thoughts arise, the meditator notices them and allows them to drift away, as though clouds or leaves, before gently returning attention to the breath. In Christotherapy, we enhance and deepen this practice to facilitate detachment, the release of knots and blocks in the body's internal flow. While valuable in its own right, breathing meditation is a powerful home practice for reinforcing and extending gains achieved through a rigidity challenge. Breathing meditation and rigidity challenges are both symptomatic therapies. They relieve symptoms without seeking cause. While knowledge of cause is beneficial, it is not always accessible. We know that in the womb we are exposed to the hormones of our mothers when they suffer trauma, which can establish a lifelong bias towards panic. Serious trauma may also be hidden behind a veil of amnesia, which is lifted only when the subconscious believes that we are strong enough to process the experiences. Even when the cause is known, that alone is not sufficient for growth. Those who suffer from childhood neglect often lack an assertive moral voice. Therapy facilitates development of the voice, liberating them from dysfunctional relationship patterns. Often there is a yearning for recognition from the authority who failed their role in the critical stage of development. When that authority is estranged or deceased, the client must find comfort within. We should recognize that in offering symptomatic therapies, we are following the methods of the psychiatrist. Psychiatrists are prohibited from analysis of cause. They nonetheless provide relief, not only with chemicals, but with sensory exposures, such as biofeedback, polyvagal therapy, or EMDR. Brainwave analysis shows that such experiences are powerful teaching methods. The mind seeks harmony and will explore new patterns when they are offered. So don't be shy about offering breathing meditation to clients who are struggling with hidden causes. You are not treating their trauma. You are helping them to find inner peace. The knowledge that they aren't broken may be the first step on a journey to healing in the care of a clinician. The breathing meditation protocol is deep. You will find the details in the one sheet included in your course materials. You may want to pull it up and pause the presentation while you study the relationships between the outline here and the goals in each phase. The client progresses through layers of awareness. Steps 1 through 5 disrupt the pattern of anxiety with a demonstration that we can choose to focus on what feels good. You may recognize it as a preliminary in the progressive relaxation. In our therapeutic strategy, this phase dissolves barriers, restoring flow of energy and attention. Dissolving of barriers continues with the second phase, learning to manage the intrusive thoughts that disrupt constructive engagement. Having laid this discipline as a foundation, the deeper work of healing begins in the third stage. We allow the body to speak to us, using the permissive attitude of the first phase to encourage relaxation and recovery in distressed tissues. In this process, attached experiences and emotions will be revealed and released gently using the skills developed in the second phase. The therapeutic goal, however, is to give the body permission to heal. The fourth stage turns attention toward external ecology, or the dynamic of exchange with the world. Breath, food, knowledge, and recognition are illustrated, but collaborative partnership is essential to every aspect of our existence. In the fifth stage, we graduate from management of intrusive thoughts to actively organizing them according to their moral utility, establishing ownership of our mental ecology. In the sixth, final stage, we engage the wisdom of the heart, whose rhythms are the most profound guide to organic well-being. The meditator is encouraged to seek within it for the gateway to the energies that bear witness to and safeguard our virtue. Clearly breathing meditation seeks to expose hidden layers of the personality to conscious awareness. Naturally, clients dealing with our priority syndromes may surface painful memories and harsh expectations. As therapists, we are responsible for guarding their mental balance, ensuring that the past does not disrupt their engagement with the present. To accomplish this, we introduce each phase of the breathing meditation in the protective blanket of therapeutic trance. We monitor for abreactions, physical evidence that the inner reality is painful. This includes tears, twitches, distorted facial expressions, crossing of the limbs, and moaning or crying out. When these occur, we wait for the expression to pass, then reprise the dialogue. If the abreaction recurs, we should redirect the trance to calming imagery. In the post-trance dialogue, we gently ask, what was happening when I was suggesting? If the issues revealed are out of scope, we reassess the therapeutic process, potentially deferring deeper exploration until a clinician has been engaged. Note that in general, abreactions are not to be feared. Muscles wound tight in opposition will spasm when the mind relents. We need be concerned only when the second abreaction demonstrates that the tension has immediately resumed, which is a signal that the subconscious is not ready to confront the underlying issues. As each phase is mastered, abreactions will pass, and the pace of the trance progression will increase. The client learns to navigate through the layers of awareness, guided only by a phrase or sentence. This facility allows us to allocate most of the trance to the active phase. Later, we will return to breathing meditation as a self-guided practice for spiritual deepening. When used symptomatically, however, home practice should be gated to progress in session. Progress in breathing meditation will often stimulate dreams and memory reprise. These topics should take precedence during investigation in the next session. We should be concerned when the material is re-traumatizing, which must be distinguished from the moral fatigue that accompanies repudiation of its influence over the present. When the former occurs, we should address the underlying issues before resuming the progression of the breathing meditation practice. Inherent to the triune disorder is a conflict between the body and the mind. Because the mind cannot resolve social repression, the body is made to suffer. While the conscious mind may suppress awareness of that irritation, in the subconscious those signals reinforce the expectation that we are socially ineffectual. As a method for softening the ties between the social and physical experience, the Rigidity Challenge builds subconscious confidence in the therapeutic alliance. Used skillfully, the client releases suppressed capacities for adaptation and growth. Upon first exposure, you might question the logic of the dialogue. The client is told to try to move their rigid muscles, which seems like an invitation to escape resolution. The suggestion to try, however, implies failure. Moving also requires planning at the subconscious level, which is resisted according to the principle of least action, which holds that stability is preferred over change. Finally, the action is suggested in a context that leads the subconscious to expect a release of inner tension, which motivates it to resist the external authority's suggestion to escape. The total effect is for the conscious mind to concede authority over physical experience to the subconscious mind, allowing the final suggestion to let it go to propagate throughout the body. The rigidity challenge adapts to the client's condition. This slide presents the investigative outline. If discomfort is linked to social repression, we expect it to be accompanied with a distressed mood that triggers discomfort. Once the emotional state is identified, we want to know what would follow when the mood is dispelled. Triune discomfort is often migratory. According to posture and activity, it pops up in different places. We investigate to ensure that we focus the rigidity in an unaffected part of the body. We may also uncover that vulnerability is more evident that on one side or the other. When carried behind, the client is seeking to shield themselves. Right side discomfort often relates to difficult relationships with males, while tension with females will tend to manifest in the left. Noting again, the left-handed clients will show the reverse. We then need to choose a target for the rigidity challenge. Typically, this will be hands and arms, but we can also focus on knees and thighs, or feet and buttocks. Generalized discomfort leads to balanced pressure of one hand against the other, while if the discomfort is focused on one side, we build pressure against furniture, floor, or another part of the body. For example, the palm pressing against the thigh. Let's walk through the trance dialogue. In what follows, words and brackets are replaced by the terms from our investigation. In this case, we will assign the target to the palms, the distress will be frustration, and the relief will be acceptance. The dialogue then starts in a mildly maternal tone. We will now work to release frustration. You will focus it between your palms. Raise your hands and press the palms together, wrapping the fingers to create a firm grip. We will use a count from 5 down to 0, and with each count, frustration will move into the space between the palms. When we reach 0, the palms will press together like steel, compressing the frustration into a vanishing dot. We use a paternal tone in this next sequence. Starting now at 5, moving the frustration from the body and mind into the palms as the surrounding muscles tighten. 4, the muscles continue to tighten as frustration flows down into the palms. 3, squeezed into the palms, the frustration begins to compress. 2, very, very tight now. 1, pressing so tightly that the palms feel as though they have melted together. And 0, the palms lock together like steel. Precede immediately here as the muscles will fatigue. Locked so tight that though you may try to separate the palms, you cannot. Try as hard as you can, for in trying, you search out all the remaining frustration, compressing it into a tiny point. A brief pause, and now with a deep inhale, holding as you prepare to, now maternally, exhale and let it go. Just letting it all go. Wiggling your fingers and shaking your hands gently, even raising the palms to your face and blowing gently on the palms to send the frustration away as acceptance enters and you drop even deeper into trance. The rigidity challenge softens expectations that are held in muscular tension. In the aftermath, the subconscious restores physical ease to its rightful importance, but needs an alternative method for managing social conflict. This need is fulfilled by the descent deepener, which we will cover in our next lecture. The rigidity challenge is often used as a preliminary to desensitization, the Swiss Army knife of transactive therapy. Desensitization will be covered in a 4-lecture series after we discuss panic therapy. We have focused on triune disorders as a chronic condition that prevents growth through self-limiting expectations held in physical tension. With a long-term client, however, our plans for a session may be disrupted by tension that is tangential to therapy. To bypass these manifestations of subconscious resistance, the rigidity challenge can be used as an induction. Golf has been called a good walk ruined. We usually take it up in our later years when the division between conscious and subconscious minds impedes refinement of motor control. Worse, needling by competitive companions can link incompetence to social frustration. A bad day on the links is a great example of an incidental aggravation that nonetheless may interfere with therapy. Rumination is a trance process that conditions the subconscious to take up problem solving in dreams. When the client comes to our office in trance, our first concern is to get them out of trance so that we can build rapport in the alpha state. Channeling aggravation into the body is a stopgap that disrupts aggravation. We need to be careful to avoid establishing this practice as a habit pattern. The circuitry that manages our physical well-being is not designed to solve social problems. Running to relieve social distress, for example, can lead to shooting pains in the lower torso and legs. As an induction, we use the rigidity challenge to disrupt the trance state, counting the client out immediately so that we can turn our minds toward productive problem solving. The dialogue for the induction is similar to the deepener. Without further commentary, then we begin. Let's use that frustration to create a deep trance. Interlace your fingers with your thumbs up. Hold your hands out in front of you, focusing your eyes on the thumbnails. Don't blink. We will use the count from 5 down to 0, and with each count, the frustration will become pressure in your palms. When we reach 0, your arms will become like steel. 5, the pressure increasing in your palms. 4, tension mounting in your biceps and shoulders. 3, arms becoming stiffer and stiffer. 2, stiffer and stiffer. 1, your arms becoming stiff as steel. 0, your arms are now as rigid as steel. With a blink, continue. Notice the fatigue in your eyes. You are blinking, blinking, eyes closing, closing and closed. Focus on your breathing, allowing your belly to soften. Notice the slight movement of your arms, a slight movement towards your lap. With that descent, your awareness heightens as the body, mind, and spirit soften into harmony. Just allowing the descent to continue at its own pace, knowing that when the hands reach your lap, you will enter a deep, comfortable trance. When the hands reach the lap, deep trance. The dialogue here leverages natural mechanics, the overload of attention that turns from the arms to the eyes and belly, and the softening of the belly that causes the shoulders to oscillate slightly when breathing. In focusing attention on the downward stroke, we create the expectation of descent. The anticipatory suggestion for harmony associates a mental outcome with the descent. The client may resist, except that, having come into the office in a trance, they are in a suggestible state. They can resist, but the body will reject the wasteful expenditure of energy. To emphasize, this is done before the investigative beta state portion of the session. A brief imagery journey to a favorite place may cement the state of calm. Building on our example, one of golf's pleasures is the opportunity to walk in a garden setting. Removing the competitive stress from the experience may support the subconscious to maintain the fluidity so essential to refinement of motor control networks. When complete, count the client out and ask, "How was that?" The Rigidity Challenge is a powerful therapeutic tool, allowing us to disentangle moral and social networks that have disrupted the networks that manage our organic well-being. This lecture should have prepared you to use these techniques, but also given you how and why, understanding to use them for best benefit. That physical tension occurs when we face social stress is part of our ancient evolutionary heritage. How should we manage it in daily life? Well, we are told to count from 1 to 5, take a deep breath, and relax so that our adversary recognizes that we would like to negotiate towards a win-win outcome. While our rigidity challenge counts from 5 down to 0, the end goal is the same, shifting energy from physical networks to social networks. Letting go of internal tension is an essential skill. After we have demonstrated its value to the subconscious, the client may be more receptive to those simplistic prescriptions for conflict resolution. In our next lecture, we will expand upon the descent deepener.